Good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh. I'm glad to get invited to speak here. I actually replacing Prof. Kiatruk Sungtam that is not available today. So I'm going to lead you to a story of the patient. So this is the case that I want to present. This is Mrs. L.A. She's a 40 years female. She got HIV test during her pregnancy back in 2009. And at the time, she started with the D40, 3TC, and lopinavir, ritonavir. It's not usual combination, but because she's pregnant, then the doctor decided that she should start with the lopinavir, ritonavir. She admits sometimes not taking the drug regularly back in 2013 to 2015. Her previous test is no hepatitis B or C, no history or TB or other opportunistic infection. Her current height is 158 and body weight is 68 and with high BMI, with her waist circumference is 86 centimeter. So this is her history. So he start using the stafudin, lamivudin, and lopinavir ritonavir in 2009, and then she cannot have an access to routine viral load, but we can see that the CD4 is increased, and in 2012 the viral load is below 40. However, due to this, that at the time not stafudin available, and with the phasing out of the stafudin, she cannot use stafudin anymore. So we changed the regimen to AZT, 3TC, and lopinavir, and we can see that the CD4 is increased, but like many other patients, not many can have an access to viral load. We can see that the CD4 is stable, but we don't know the viral load result. So she had diagnosed with hypertension 2 years ago, taking amlodipine 55 milligram once daily, and now the recent blood pressure is 150/80. She said that her mother died at 60 years old due to coronary heart attack and hypertension. Her recent triglyceride is 3 to 5 milligram per deciliter, and total cholesterol is 315 with HDL low and the LDL is high, but the normal fasting blood glucose. So we can see that many people have mentioned that cardiovascular disease is our next problem, and this is the data from the Treat Asia, from over 8,000 patients with a median follow-up of 7.5 years. We can see that the number of cardiovascular disease is until 5.8%. And the analysis show that the development of non-fatal and CVD was associated with older age and treatable risk factors such as high blood pressure, triglyceride, cholesterol, and BMI. So it's not very specific to HIV, but maybe it is still reported, underdiagnosed in HIV population. So if we see this woman, the age is 42, and if we put in the Framingham risk calculator, where you can find in the internet, we can see that the risk of having myocardial infarction or death for this patient is 10.6%. And if we're using another calculator, if we use the ISCVD risk calculator, the risk of heart disease or stroke in 10 years for this woman is 16.5%. And based on that, it is recommended that the patient should start the moderate to high intensity statin and control the high blood pressure. And of course, we should ask that he should do something with the obesity problem. And yeah, fortunately, we have some study that the patient include in this study. So this is, are you familiar with this picture? Well, yes, this is fibroscan. But if we add one more test, the blue one, it's the CAP. So this is a fibroscan with the control attenuated parameter. So we can see her number is 277. Fibroscan is one of the good diagnosis, non-invasive for diagnosing NAFLD, non-alcoholic fatty liver disease. And the other option is using the MRI proton density fat fraction. And if you see this number, that we can see that the patient had steatosis grade 2, so she's already had NAFLD. And if you read more, we can see that NAFLD in HIV is maybe our next big thing. And it is not just one problem, that's multifactorial pathogenesis involved, not only HIV, but also metabolic syndrome, bacterial translocation, oxidative stress, aging, and everything. Then we know that NAFLD now will increase the risk of coronary disease and also other diseases that can cause mortality in our HIV patient, including obstructive sleep apnea, chronic kidney disease, cancer, and other cause of mortality. My first question is, would you switch treatment to decrease the cholesterol level and severe risk in this patient? Yes. B, no. And C, do you want to wait for more information? So please vote. Well, I can see. Well, there are one people choose D. Maybe this is the first time we use this voting. Okay. Yes. So we can see. I'm sorry. Well, there are many studies actually, because the patient using PI, there are many trial to switch PI to NNRTI or any other drugs with better lipid profile. And if you can see, this is an old data that if we change the PI to nevirapine, the cholesterol level can decrease to 27% with efavirenz 10%. But if you give lipid lowering agent, it could also decrease better than just changing the PI to NNRTI. So the answer is, maybe I personally will wait for more information and ask the patient to have the viral load. So now she come out with the test. So because he had ever not adherence to the treatment, so her viral load is 15,300 copies per milliliter. So this patient definitely had a virological failure, even though we can see that the CD4 is not decreased yet, and the patient still looks okay. So which combination would you prefer for her second-line therapy? She was hepatitis B negative when she started the treatment, but we don't know what happened. Now she's hepatitis B positive with the eGFR is 87 mL per minute for 1.70 ml. So which one do you choose? Number 1, ACT3TC efavirenz. Number 2, ABC3TC efavirenz. Number 3, TDF FTC relpivirine, or TDF3TC efavirenz. I think you should start to vote now. Well, I think most people choose the simple one, the A-tripla or TDF3TC or FTC efavirenz. Yeah, and still one person choose the not available option. Okay, so which combination do you think we should prefer? So if you see, this is the WHO guidelines. The first regimen, if they fail with the efavirenz, the choice should efavirenz or nevirapine. The choice could be DTG with two NRTIs, or an alternative regimen is two NRTIs plus lopinavir, ritonavir, or atazanavir or darunavir. But maybe like many other countries, dolutegravir is not available yet and not accessible. So this is what Indonesian guidelines say. So if we have the patient failing on nevirapine or efavirenz, so the second combination should be PI, but with the if TDF change to AZT, and if AZT change to TDF. The patient, we basically think that the first line should be an NRTI, then the second line should be lopinavir, ritonavir, because that's the only available PI in Indonesia. So this patient, for the patient, the first line is lopinavir, ritonavir. So another option is we can use the NNRTI for her second line combination if dolutegravir is not available. But if you see in Thailand, there are more alternative for the first line. So rilpivirine is one of the first line preferred in Thailand, and if not intolerance, you can use lopinavir, ritonavir, or atazanavir, and INSTI if available. However, in Indonesia, we only use rilpivirine if the patient is not tolerable to nevirapine or efavirenz. So, since the patient had hepatitis B positive, choosing the AZT is not reasonable for the patient, and DTG is not available. If we choose the abacavir, we have to consider that abacavir have a higher cardiovascular risk, so it's not a good option for this patient. So between tenofovir, 3TC, and rilpivirine, we can use rilpivirine or efavirenz in this patient. So the doctor decided that she used the CDF, 3TC, and rilpivirine, and adding atorvastatin 220 milligrams. This is a moderate intensity statin. Our comments, and we can see that the triglyceride, cholesterol, LDL is increased, then LDL is also decreased in this patient. So this is what happened after she changed the drug to the TDF, FTC, and rilpivirine. We can see that the CD4 is more or less the same, and after 1 year, the viral load decreased to below 40. However, the patient come again with 1 month of high fever, nausea, abdominal pain, and decreased body weight. We found that an epigastric mass found in a physical examination with the pain, and she mentioned that the pain is a fast visual analog scale is 5/10, so it's pretty pain for her. And we can see the hemoglobin decrease and high leukocyte and just small elevated LDH, but amylase and lipase within normal range. Normal CA99, it's a marker for pancreatic carcinoma, and CD4 is just a little bit decreased. And in ultrasound, we found the solid nodule-like mass abscesses in the body of pancreas with multiple para-aortic lymphadenopathy. So this is her CT scan. We can see there is a pancreatitis with abscess formation in corpus of the pancreas with multiple conglomerated para-aortic and peripancreatic lymphadenopathy. So luckily, we have an access to do the endoscopic ultrasound. Then it's not me who can do this test. So The doctor do the aspiration using the endoscopic ultrasound, and then we test for the acid-fast bacilli, and it is positive. So this is a case with the pancreatic TB, and then we start with the antituberculosis, rifampicin, isoniazid, ethambutol, and pyrazinamide. And the symptoms of this patient, resolution in a week. So it's a good case for the patient. So are you going to modify the antiretroviral therapy for this patient? Yes? No? Or wait for more information? Please vote. Wow, that's good. So everyone, 20% say we should modify the treatment. Yes, because the patient used rilpivirine, we need to change rilpivirine because the drug interaction with the rifampicin. So the other option is changing the patient to efavirenz. So we need to change the patient to efavirenz because he's also using the rifampicin, and rifampicin cannot be used together with rilpivirine. So this is the result. So the patient taking antituberculosis for 9 months, the adherence was good, and we can see that she had a chance to test for her HBV DNA, and we see that the HBV DNA level is undetectable at the moment. And this is the continuation. As we can see, she's using the single drug of tenofovir FTC efavirenz. The CD4 is still around 400, and then we stop testing the CD4, so we're focusing more on the viral load. As you can see that in December 2018, the viral load is increasing to 20,000 copies per ml. So this is definitely not the virologically suppressed, not the virological blip where the patient can have an increase but not high, but then decrease again. Not really the persistent low level viremia because it's already above 1,000 copies per ml. So what we see in this patient is actually the virologic rebound or the virological failure. So this is my last question. Which third line do you prefer to use in this patient? Whether it is TDF, FTC, darunavir, ritonavir, whether it is DTG with darunavir, ritonavir, whether it's ABC, 3TC, darunavir, ritonavir, or TDF, FTC, DTG, and darunavir, ritonavir. Please vote. Okay, so most people choose the hardest drug, the fourth drug for this patient. Okay, so it's actually good if we have a HIV drug resistant test, especially if patient failing with the first and the second line and highly treatment experienced at this patient. But however, for this patient, HIV drug resistant test is not available. In my country, there is only one lab that can do the HIV resistant test, and the result will come out a month, and the patient should pay by themselves, and it costs almost $300. So it's not accessible for many people. So if we remember, this is what Prof. Kiat taught me. If we found a patient with failing NRTI, we can see it is the time of firing antiretroviral, the yellow line. If the patient use failing antiretroviral longer, we can see there are more times mutation come out, And in the beginning, if you use AZT3TC or D40, if the patient only had 3TC and resistant, the patient can still use AZT340 and TDF. But if it is getting more and more number of times, we lose more option. ABC, TDF also not an option. And if we have more and more times, there is no option available for this patient. ABC is not available if the patient already is not reasonable if a patient already resistant to tenofovir and AZT. So it's not a good option for the failing regimen. And for the boosted PI, we know that the PI has a higher level of barrier to resistance. So if the patient failing with the lopinavir, and there are more and more RAMs developed, and if it is more than 5, the darunavir, ritonavir is still an option. If the patient fail with lopinavir and atazanavir, darunavir, ritonavir might be possible. They might not be resistant to darunavir, ritonavir. And with the NRTI, in our patient, if we fail with the rilpivirine, we fail with the efavirenz, and then we probably don't have RAMs. Any NRTI still sensitive to this patient. So this is what WHO recommendation for sequencing the first, second, and third line. So if we use the lopinavir in our patient, we use lopinavir, ritonavir in the first line. So the second line, since we don't have DTG, so in our patient we change to efavirenz. So if efavirenz already failing, nevirapine already failing, lopinavir, ritonavir already failing, maybe the only PI that's still left is darunavir, ritonavir. And this patient hasn't been exposed to any INSTI before, so it's probably that the patient still have no resistance to dolutegravir. And we can see that dolutegravir price is going down. So in this patient, it will be good if we use the darunavir, ritonavir, and dolutegravir in this patient. And then, if possible, adding 1 or 2 NNRTI if the patient had hepatitis B. This is a study of ACTG A5299. There is actually not enough data what to use in the third line candidates. Sorry, this is changed. If we have a resistance test, and then the patient randomized to whether if the patient resistant to lopinavir, ritonavir, but susceptible to darunavir, etravirine, and never use raltegravir. So they randomize between using the best available NRTI with raltegravir and darunavir, or using etravirine, raltegravir, and darunavir, ritonavir, or using raltegravir, darunavir, and TDF FTC. And the other cohort is using best available drugs, and the D cohort is only available as the local and study supply. And this is the result. If we can see the patient who used the raltegravir, darunavir, and TDF FTC, or etravirine, raltegravir, darunavir, and other best available NRTI, raltegravir with darunavir, actually had a better result compared to others. And if we remember that the patient who had hepatitis B co-infection with HIV, we should include antiretroviral, TAF or TDF plus 3TC or FTC as an NRTI backbone of fully suppressive regimen. If we know that the patient is actually, we see that her HBV DNA is undetectable, so the TDF plus FTC or 3CC is actually still good for her hepatitis B, but it's not working anymore for her HIV. So if TDF and TEF cannot be used, alternatively is to add entecavir to fully suppressive antiretroviral regimen. But entecavir is something you should buy for themselves if you need entecavir. And if we stop any drugs with activity against HBV, could possibly pose the patient to serious liver damage as a result of HBV reactivation. And we sometimes see the hepatitis failure because of stopping the anti-HBV among hepatitis B co-infection. So which third line you prefer to use? Well, I think the most common answer is the correct one. So we need to use 4 drugs for this patient, which is very expensive. But if you have access to resistant, then sometimes we could see that there are many other options, or maybe just the patient didn't take the drugs at all. And thank you, terima kasih.
Thank you, Dr. Evy, for your excellent talk. So now we have time for a question from the floor. Any questions? So Dr. Evy showed the case in the real life clinical practice in resource limited setting that which HIV drug resistant may be not available in that area. So in your case, if your case has a low kidney function such as eGFR less than 60, which regimen will you prefer to use in this patient?
Yes, actually we only have AZT, 3TC, tenofovir, abacavir, and FTC in an NRTI group. You mean in the last situation, or in my other?
In the last situation.
In the last situation. So if the patient had, you mean like if we need to use these combinations?
Yeah.
Another choice is reducing the dose of tenofovir according to the recent eGFR. Because we still need a tenofovir for her hepatitis B co-infection.
Yeah. Okay. Any question? Okay.
Hepatitis B viral load.
When we switch?
No, you have got diagnosed, the patient got HBs antigen positive, right? So do you also check the other parameter or hepatitis B infection?
Yes. At that time, we don't have a chance to check the HBV DNA. We have an access, but it's still expensive. And in our guidelines, actually, we do not need to check the HBV DNA for the HIV and hepatitis B. As long as their hepatitis B surface antigen positive, then we can start the patient with the 2 drugs of anti-HBV therapy for HIV co-infection.
Okay. Okay, no questions. So thank you, Dr. Evy. So we will move to the next presentation.